Hello, good afternoon, everyone. Thank you for joining us in track 10 of APICS 2020. It has been a long day, but as we go on to track 10, we are excited to have a very good lineup of speakers who will be sharing their experience and expertise on management of respiratory failure, pre-COVID-19 evidence, and can we apply to this pandemic. As we reel from the effects of COVID-19, I know a lot of you have joined us from various parts of the world. I hope you are keeping well and coping with the effects of this pandemic, which has really hit us very hard. But despite all this, we are happy to have a common platform where we can meet on this APICS 2020, where we can share our experience, expertise, and questions and learn from one another. We have three speakers for today, for this track, covering management of respiratory failure and how it applies to this pandemic. The first speaker will be Dr. See Kay Choong, and subsequent two speakers will be Mr. Ivan Gerald and Dr. Esther Tan Qiao. Unfortunately, because of time differences and prior commitments, the latter two speakers, Gerald and Esther, would not be able to join us physically, but it will be we'll be showing pre-recorded lectures by these two speakers. There will be a Q&A session at the end of every talk, and feel free to just submit questions via the Q&A tab at the bottom of your Zoom screen. Okay, so without further ado, I would like to invite our first speaker, Dr. See Kay Choong from National University Hospital. And Dr. See holds a lot of portfolios in his public service in the health institution. And he is here as Senior Consultant, Division of Respiratory and Critical Care Medicine in National University Hospital, Singapore. Associated Designated Institutional Official, Residency Program, National University Health System, and Vice President, Society of Intensive Care Medicine, Singapore. His clinical and research interests include cardiopulmonary physiology, critical care ultrasonography, pleural disorders, smoking cessation, epidemiology and biostatistics, healthcare quality improvement, and medical education. So without further ado, we have the immense pleasure and honor of having Dr. See Kay Choong deliver his first talk. Dr. See, over to you.
Okay, thanks, Chairperson, for your kind introduction, and to all our attendees and friends. Hope you have been enjoying your conference. I would like to share my screen now. Right, able to see the slide?
Yes, we can.
Okay, thank you. Okay, so the topic that we are concerned about is mechanical ventilation of COVID-19 pneumonia. And these are my disclosures. So let's start with a case of a 72-year-old man. This is a real case of COVID-19 who presents with diabetes, hypertension, and dyslipidemia. There are bilateral infiltrates on chest radiograph, as you can appreciate here. And he actually comes in with acute respiratory symptoms as well as hypoxemia. So this progresses over time, and infiltrates got worse, hypoxemia got worse, and he required mechanical ventilation and intubation. So how can we best adjust our ventilatory settings? How can we adjust our ventilatory strategies to optimize his survival? We do have to consider many of the factors, such as tidal volume and plateau pressure, prone positioning, the use of positive and expiratory pressure, hemodynamic considerations of our ventilatory strategy, asynchrony and paralysis, as well as weaning and extubation. Well, it is without doubt, and I think no one will really argue against this, that tidal volume and plateau pressure as part of lung protective ventilation are critical kind of measures as well as targets. So normally we want to keep the tidal volume low, anywhere between 6 to 8 mils per kilogram of ideal body weight, and a plateau pressure of less than 30 centimeters of water. And many studies after this randomized controlled trial published 20 years ago have shown that adherence to these targets are associated with survival and non-adherence are associated with mortality. In addition, about 5 years ago, Amato and colleagues did a retrospective combination of 9 previously done trials showing that another type of pressure was important to improve survival. And this is called the driving pressure, which we are probably quite familiar about, the difference between plateau pressure and the positive end expiratory pressure, or PEEP. And it appears that there's a very strong monotonic relationship between increase in driving pressure as well as mortality, such that beyond about 15 centimeters of water, mortality increases fairly drastically. So a lot of times we try to keep driving pressure less than 15 as well. Well, thankfully, if we do keep tidal volumes low, between 6 to 8 mils per kilo, the vast majority of patients would have also tidal volumes less than 15 centimeters of water. However, in patients with very stiff lungs, with very low lung compliances, especially those with lung compliances, or rather respiratory system compliances less than 30 mils per centimeters of water, then one has to be careful, because in such patients, even if we lower the tidal volume, the driving pressure might still exceed 15 centimeters of water. So in such patients, we probably have to be careful. We have to measure directly the respiratory system compliances using our inspiratory pause maneuvers and adjust our tidal volumes accordingly. But is there a way to improve the respiratory system compliance without really tweaking the ventilator settings directly? Well, one way could be the use of prone positioning. So this picture comes from the now landmark paper by French colleagues, showing that using prone positioning, there could be some beneficial effects. And indeed, these effects are due to factors such as really unloading of the dorsal parts of the lung, allowing these parts of the lung to expand and be aerated. And with increased ventilation, with improved ventilation, O2 goes up, CO2 goes down, and of course, the respiratory system compliance also improves. And this was published about 7 years ago in the now landmark trial called Proceed, showing that among patients with moderately severe or severe ARDS, as measured by PF ratio of less than 150, proning, early proning within 36 hours of intubation for a prolonged period of time, more than 16 hours, is associated with an improved survival, with a number needed to treat of only 7. So certainly prone positioning is a very helpful measure when the PF ratio is less than 150. But is there another way to improve respiratory system compliance? I think one other very, very common method that we use is to increase the PEEP in the hope of really improving the recruitment of the patients and keeping lung units open. But how do we know which patients actually benefit from higher PEEP? Lately, there has been a ratio that has been proposed called the recruitment to inflation ratio. And the formula here looks a little bit complicated, but really all it means is that there's a ratio between the recruited lung compliance and the compliance of the ARDS baby lung, which is really the respiratory system compliance at a PEEP of 5 cm water, or at a low PEEP that's just above the airway opening pressure. And the recruited lung compliance is dependent upon something called the recruited volume, which is really the volume expired from a higher PEEP level of 15 to a PEEP of 5 cm water, minus the volume predicted by the compliance at a low PEEP of the baby lung. So with some arithmetic, the RI ratio can be calculated, and anything above 0 is actually good, but a threshold of 0.5 has been proposed to demarcate, or rather identify, patients that are highly recruitable. But how is this applicable to COVID-19 pneumonia? It has been studied, and really in this moderately sized study of 25 patients, the large majority of patients, 16 out of 25 or 2/3, actually are highly recruitable. And interestingly enough, the initial PF ratio and the initial static respiratory system compliance do not predict whether the patients are recruitable or not. So we should not be put off trying to recruit patients, even if respiratory system compliances appear to be higher than what we expect. And in addition, if patients are poorly recruitable early on, they may also become recruitable later on. So don't lose hope. Patients can still be recruitable later in the course of disease. And some of us might be blessed to have more advanced tools like the tool called electrical impedance tomography, or EIT for short. And this allows us to directly visualize areas of lung inflation and aeration, and also realize areas that are over distended. So if we believe in the sweet spot concept, then we would adjust the PEEP levels to maximize aeration and minimize over distension. But is the lung the only thing that we are concerned about? I think if we have attended the talks earlier in this symposium, we realized from one of the earlier tracks that the right ventricle is a chamber of the heart that is very important. In fact, this picture comes from a very early series of COVID-19 patients, of only 5 patients, published in the New England Journal of Medicine, showing that with some patients with COVID-19, the right ventricle can be markedly distended. And we all know from the non-COVID-19 literature that in ARDS patients, when the right ventricle is distended to the size that matches that of the left ventricle, or even exceeds that left ventricle, it is associated with mortality. This is also the same reason why we need to be careful in COVID-19 patients, because right ventricular enlargement in COVID-19 ARDS has also been associated with increased mortality with an adjusted odds ratio of 4.5. But of course, we can say that this right ventricular dilatation might not be due to ARDS per se, but might be due to pulmonary embolism. And we do know that COVID-19 is some form of a hypercoagulable state. And well, some studies have shown that, well, right ventricular dilation does occur even when PE is absent. So in this series of 105 patients, 31% of them had fairly large right ventricular dilatation, and with 5 of them with PE. So the vast majority still do not have PE, and we still need to be careful even in the absence of coagulation. And in this same paper, it showed that the acute dilatation of the right ventricle was associated with mortality, and in this case, the patient did not survive. So how do we know whether right ventricle is dilated or not? Thankfully, there are information from the non-COVID times, and this is a score called the acute cor pulmonale, or the ACP score, that can help us. And this score basically pulls together 4 factors that strongly predict the presence of acute cor pulmonale. And these factors actually, in the pathophysiology of acute cor pulmonale, would also lead us to think that they will increase the right ventricular pressure. Well, the first of them would be pneumonia as a cause of ARDS. The second would be driving pressure of 18 centimeters of water or greater. The third would be a PF ratio of less than 150, which not only is a marker of severity, but also with hypoxemia, it can also lead to pulmonary vasoconstriction. And the fourth factor would be an arterial partial pressure, or CO2, of 48 millimeters of mercury or more, which again can cause pulmonary vasoconstriction. So if we add these 4 factors up, we have a score range of 0 to 4. And if patients have a score of 0 or 1, then they have a low risk of acute cor pulmonale, and we might not need to actually perform echo on these patients. However, if the score hits 2, 3, or 4, then the risk of ACP goes up quite a lot, and we might want to put an echo probe on these patients to find out whether they have dilatation of the right ventricle. But what can we do if the right ventricle is actually dilated? Well, we have to treat it in a way to reduce the pulmonary vasoconstriction. Well, we have to improve oxygenation, we have to reduce the PaCO2, we have to reduce the driving pressure. And one maneuver can actually do all 3, which is prone positioning. Because prone positioning can improve aeration of the lung, it can improve O2, it reduces CO2, and by giving rise to increased recruitment of lung units, it can also reduce or rather improve the respiratory system compliance and reduce the driving pressure. So a very useful maneuver to fix acute cor pulmonale. And indeed, in COVID-19 patients, the use of prone positioning has been directly demonstrated by 3D transesophageal echocardiography to really decompress the right ventricle, although this is a reversible phenomenon as for oxygenation. So if we put a patient back on supine, the right ventricle does, well, dilate again. So indeed, it might also give us cause to think whether we need to prolong the period of prone positioning in these patients so that it gives them enough time to recover on their own and improve the conditions to reduce the risk of acute cor pulmonale. Well, another maneuver and maybe medication that we might want to use in patients with severe ARDS is neuromuscular blockade. Well, there was quite a lot of enthusiasm about it initially in 2010, when the use of cis-atracurium early in the course of ARDS was associated with survival. Although this enthusiasm was slightly blunted with the publication of the ROSE trial last year by the Petter group in the US, whereby there was no association with survival. Well, there are differences between these two cohorts, but having said that, even if there was survival benefit, the pathophysiology, or rather the way that neuromuscular blockade works, is not entirely known. But perhaps in the COVID-19 front, gives us some clues. Well, this is a small study, relatively small study, but very detailed study of ventricular waveforms in COVID-19 patients, particularly focusing on something called a patient-ventilator asynchrony, which is a matching of the ventilator settings and the ventilator breaths with the patient's requirements. Well, more about this will be discussed by the next speaker. But having said that, patient-ventilator asynchrony is associated with poor outcomes in numerous studies. Well, in COVID-19, it is no different. In patients who have died compared to patients who survived, the asynchrony index, or proportion of asynchronous breaths, are higher in the patients who have passed on. And if we apply sedatives, it doesn't seem to really work to reduce the risk of asynchrony. But if we use neuromuscular blockade, then there is a very strong signal, statistically significant signal, that asynchrony actually reduces. So really, maybe neuromuscular blockade works in ARDS by reducing patient-ventilator asynchrony, though this requires further trials and further studies to verify. Well, if the patient gets better, then what do we do? Well, of course, we want to extubate the patient and reduce the time of mechanical ventilation. Well, lately, in the last 1 or 2 years, there has been fairly renewed interest in one of the measurements that is actually available in most of our ventilators, which is the airway occlusion pressure in the first 100 milliseconds, or the P0.1 for short. So this is actually a negative airway pressure generated during the first 100 milliseconds of an occluded inspiration. Well, it's just a press of button on most of our ventilators. And what does this signify? It really signifies respiratory drive, because of the very short duration and zero flow state that this maneuver involves. It is actually independent of respiratory muscle weakness and independent of respiratory muscle compliance and resistance. So it directly tells us the respiratory drive. And indeed, such a non-invasive measure has been used to try to predict the success of extubation, with a target range of between 1.5 to 3.5. So if you take away the negative sign of this P0.1 measurement, it should fall between 1.5 and 3.5. Anything more than 3.5 means that the patient has excessive respiratory drive, which means the patient is probably going to fail extubation. And indeed, for COVID-19 patients, in this fairly small study of 28 patients, it is quite strongly predictive with an AUC of 0.84. And if the P0.1 is less than 4, I think we are fairly confident that this patient can be extubated. While if the P0.1 is in excess, then there is some indication, though we cannot be completely sure. So really, for COVID-19, it still kind of behaves like a non-COVID state. Well, during extubation itself, there could be concerns, of course, about aerosolization of secretions, especially when patients cough. And many patients actually have prolonged secretion of COVID-19 particles, and these particles can also be infective. So during extubation, we've got to keep the staff safe by minimizing the number of staff present, and every staff present should be wearing full personal protective equipment, inclusive of the face shields, as well as inclusive N95 masks, long gloves, long gowns, as well as gloves. And indeed, extubation should also take place in negative pressure room to really make sure that the infection doesn't go out of it, and also to avoid aerosolization maneuvers such as use of non-invasive ventilation after extubation. Well, some places are also quite creative, and they have created rather barriers, physical barriers, to reduce the chance of aerosolization spread when a patient coughs during extubation. And this is just one example of the many devices and boxes and barriers that have been created. Well, there is I guess it's quite natural to think that, hey, so far what we've discussed is fairly similar to really the non-COVID pneumonia management. And indeed, it could be. There has been some talked earlier on during the COVID-19 pandemic that there are some form of compliance differences between COVID-19 pneumonia and the compliance differences can really maybe categorize patients into two kinds. One kind would be those with fairly good compliances, and another category of patients would be those with poor compliances, even though the level of hypoxemia may be the same. But then again, these two categories, can transit from one another and are also found in non-COVID pneumonia states. Well, if we look at the recommendations of COVID-19 pneumonia and ARDS treatment based on these categories, really, if you look at them closely, there are more similarities and differences. So it just basically highlights that there is a range of compliances across patients with COVID-19 pneumonia, but the treatment need not differ greatly. They still need to be consistent with our prior teachings, our prior knowledge and understanding of ARDS. And indeed, the oxygen response to lung recruitment is fairly similar between COVID-19 and non-COVID-19 patients. And also the oxygen response to prone positioning is also fairly similar between these two groups of patients. A large study from the Spanish ICU network of 700 plus COVID-19 pneumonia was done. And these patients were compared to multiple prior trials of non-COVID-19 ARDS and also multiple prior observational studies of non-COVID-19 ARDS. And they found that the respiratory mechanics of COVID-19 patients was very similar to prior studies. And also the mortality was very similar to prior patients. And really, I think there are more similarities than differences in this respect. Indeed, even if there is some difference in terms of static compliance, statistically significant difference, you can see that even from this Italian study, multi-center study, there was a great overlap in static compliances between COVID-19 patients and the so-called non-COVID-19 or classical ARDS patients. So I think there are again more similarities than differences. And if you directly measure the lung weights based on CT-derived measures, again, there are so many differences. So, what is actually the difference? Well, I think one difference that seems to stand out is really the trajectory of COVID-19 pneumonia. I think this is pathogen dependent. And indeed, from the Spanish ICU cohort, one can see that the days from symptom onset to mechanical ventilation is fairly long. Well, it's nearly about, on average, about 12 days, more than a week. And even if patients were admitted to hospital, well, the days of duration between hospital admission to mechanical ventilation is also fairly long, about 4 to 5 days. So certainly longer than what we experience for the so-called classical ARDS. And if we look at the strict definition of ARDS within 1 week of a known clinical insult, then this fairly prolonged period of maybe deterioration or worsening seems to breach this time window. So maybe for COVID-19, the definition of ARDS can be loosened a little bit. Well, I think of more practical implication would be the length of time that these patients require on a ventilator, which seem to approach that of 2 weeks. So in this Spanish study, again, the same Spanish study, the length of time on average of patients was 14 days or 2 weeks on the ventilator, which is a lot longer when we look at prior studies. And this is an observational study of non-COVID-19 ARDS, where patients spend on average about 1 week. So it seems to double the time on ventilators just because of COVID-19. And really, many studies now have shown that even therapies like neuromuscular blockade can need to be prolonged in patients with COVID-19. And in this study, published critical care, 400 patients, more than half of them really required neuromuscular blockade of more than 2 days. And thankfully, these patients, while they have fairly severe hypoxemia at the start, don't really have a difference in mortality, whether you use neuromuscular blockade for longer than 2 days or shorter than that. Well, there are also other practical implications when the duration of mechanical ventilation is longer than expected. I think we need not worry too much about non-resolving conditions or non-resolving pneumonia. So I would say that we probably don't have to rush into changing therapy or doing too many investigations if the duration of mechanical ventilation is a bit longer and the patients seem to be static. Avoid the use of continued use of broad spectrum antimicrobials just because the patients don't seem to improve that quickly. We should stop these broad spectrum if cultures are negative. And also we should not need to rush into giving additional treatment if the patients seem to be static. So especially avoid rushing to provide additional treatment in terms of unproven or off-label medications. And on organizational perspective, because mechanical ventilation duration is longer than expected compared to classical ARDS, patients with non-COVID-19 pneumonia and ARDS probably requires resource planning to cater for increased bed capacity, increased ventilators, medications that are used for mechanical ventilation, and of course, ICU staffing. So back to our case of our 72-year-old man. Well, this man did very well indeed, and we have to actually consider many of the factors that we have talked about tidal volume, plateau pressure. I think we stick to our prior teachings. Prone positioning, I think also not too different from non-COVID-19 states. The use of positive and expiratory pressure should also be titrated, possibly according to compliances and also possibly according to minimizing the driving pressure. We do have to take note of the right ventricle in our ventilation. We have to also take care of asynchrony and use paralysis appropriately. And of course, in terms of weaning extubation, we have to be careful about aerosolization. And thankfully, most of these we already know. COVID-19 is quite similar to non-COVID-19. We have got to be holistic. We have to be individualized to maximize the effect and minimize harm to both the lungs and the heart, and maybe some say the diaphragm. And really, the only big difference that I can see from literature is that the mechanical ventilation duration is longer than expected. And because of this very gentle trajectory, patients might seem not to improve so quickly, but we don't have to rush into giving additional treatment. We don't have to continue broad spectrum antibiotics unnecessarily, and we do need to organize our ICU resources appropriately. So with that, thank you for your kind attention.
Hey, thank you. Thanks, Dr. C, for the very comprehensive and in-depth analysis of management of COVID-19 respiratory failure. And it's indeed a timely reminder that, sometimes less is more in ICU, and we have to sometimes, resist the urge to do much more than is needed, and just wait out for the disease course. I think there are a few questions in the Q&A section. There's a question asking, how relevant is the acute pulmonary risk score in this day and age when, we do bedside echo for almost all ARDS patients?
Well, I think it's a great question. If we are equipped with the skill of bedside ultrasound, certainly we can do it very frequently. But for most of us, we don't have the ability to continuously measure or rather visualize the echo. There is one exception that if we do have those disposable single-use transesophageal probes, we can insert it in patients, and over 72 hours, we have continuous visualization of the right ventricle. For COVID-19, the situation is nuanced a little bit because many of us are very concerned about infection spread. We put patients in isolation rooms, and we try to bring equipment minimally into those rooms. So even for ultrasound machines, there are concerns about infection control, about cleanliness, and there might be some reluctance to very frequently place a probe on patients. But personally, I think at least once a day is good enough for these patients. And if we are a bit reluctant, at least run these risk scores and have some form of risk assessment to see, which patients we should preferentially pay attention to.
All right, thanks. Yeah, so I think COVID-19 presents its peculiarities in that because of the high infectivity, there's concern about infection control, and hence there may be some modifications to management of ARDS between COVID and non-COVID patients. And in line with your reminder for us to individualize therapy in ARDS, and given how heterogeneous different patient profiles, different lung profiles may be, do you have any experience with measuring transpulmonary pressures to guide ventilatory management?
Okay, so I guess in our personal experience, transpulmonary pressures require use of the esophageal pressure probe. I do not have that in my unit, but I know that some folks do that. I think initially there was quite a lot of enthusiasm with publications of an early trial in the New England Journal showing that using transpulmonary pressures to titrate PEEP in the setting of ARDS was helpful in terms of improving survival for a subgroup of patients with very severe hypoxemia. But later on, a follow-up study published in JAMA by the same group didn't show that mortality benefit. Having said that, I think this area is still under quite a heavy investigation. So I wouldn't close the door on transmarine pressures. But if we don't have it, I think don't fret. There are still many things to optimize, right? Tidal volumes, plateau pressures, driving pressures. And I think if we pay close attention to this, pay close attention to the changes in our patients over time, we can still do fairly well.
Thank you, thank you. So once again, join me in thanking Dr. C for the very detailed and insightful talk. Thank you once again, Dr. C.
Thank you. Thanks.
All right. Okay. So we shall move on to the subsequent two talks. And for those who have just joined us, the next two talks are pre-recorded sessions because of time zone differences and prior commitments. The next two speakers will not be able to join us physically in this platform. But nonetheless, keep your questions and coming in via the Q&A tab found at the bottom of the screen. And we will forward your questions to the speakers who has promised to come back with answers, and we will upload them onto the APICS website in 2 weeks' time so that you can follow up on your questions and find out the answers. So without further ado, I will go on to the second talk by Ivan Gerald Lee, titled Stop Fighting the Ventilators, Addressing Patient-Ventilator Dyssynchrony. And having trained and credentialed as a registered respiratory therapist in the United States, Ivan has been working in the public health system in Singapore for almost a decade. And he has recently joined Woodlands Health to set up a respiratory care department with an expanded scope of practice for respiratory therapists to attend to the respiratory care needs of patients. Ivan has a very keen passion for promoting respiratory care education through his speaking engagements in Singapore and over the region. So without further ado, we will play his pre-recorded lecture and enjoy.
Hi, good afternoon, everyone. My name is Ivan, and welcome to the Asia Pacific Intensive Care Symposium 2020. Today, I'll be discussing with everyone some of the key issues concerning patient-ventilator dyssynchrony. So a little bit of background about myself. I was trained as a respiratory therapist in the United States. And upon coming back to Singapore, I've been working in the largest and oldest tertiary care hospital in Singapore till about a year ago when I joined another new hospital to set up the respiratory care department. Okay, so first of all, I have to declare that I have no conflict of interest pertaining to the content of this presentation. I received no support or commercial funding for this presentation, and I do not support or endorse any specific brands of ventilators. And images used in this presentation is purely for educational purposes. This, I definitely have to say this because it's hard to talk about patient-ventilator dyssynchrony without sharing some pictures of ventilators, all right? So everybody who is familiar with ICU know that whatever we do with the ventilator is not benign, and it certainly has some disastrous outcomes, especially if we do not know what we are dealing with. And I do not need to point out to you that that can be potentially injurious to the patient, depending on what we do, and specifically if we do not monitor the patient's effort and how the patient-ventilator interactions take place, there might be some potentially disastrous outcomes for the patients. So now reflecting back on the past few months, we have to ask ourselves, how has the pandemic actually altered and changed how we manage ICU patients, specifically patients who are on mechanical ventilation? So I would like to point your attention to this paper that's published very recently, actually detailing how COVID patients require high amount of sedations because they are typically hard to sedate. And they actually put out a recommendation saying that deeper sedation levels may be required to promote ventilator synchrony in patients with severe ARDS. And we have to ask ourselves this: so what are the implications of administering heavy sedation? Like, do we want to get them fast through the ICU stay? Do we want to prevent intubation at all? We have to ask ourselves this because it is also in light of this that we know that patients, COVID patients actually do not typically respond to PEEP. So our strategy that we have looked at is to do prone positioning for those with moderate to severe ARDS. And we have to ask ourselves this because we take this all the prone positioning guidelines from the Percival trial that was actually published in 2013. And it says that we have to prone the patients for up to 16 hours, and neuromuscular blocking agents have to be administered for at least the first 48 hours. I cannot imagine being lying in a prone position for 48 hours and then if I'm wide awake and I'm not paralyzed. So depending on what studies you refer to, what guidelines, the guidelines have recommended at least 12 to 16 hours. So we are also looking at very long duration. So that in itself has some potentially negative outcome for patients, specifically when we are looking at the really sick ones who tend to be really old, that get into ICU and get severely ill. So these are the patients that we have to be really careful about totally wiping out their respiratory drive by administering neuromuscular blocking agent or administering heavy sedation. What are the implications and that will result as this treatment? So we know that and we understand that prolonged passive mechanical ventilation has negative outcomes and impacts for patients. Specifically, we are looking at really prolonged stay in the ICU, in fact, longer than intended, because when you sedate them too heavily, you don't get to assess them. So that's why nowadays we actually do a daily awakening trial to stop the sedation and check and assess if the patients can be weaned off mechanical ventilation. It is really understated how muscular atrophy is a big issue for patients who are on prolonged mechanical ventilation. The muscle wasting is really real, and it is really a vicious cycle because the more they cannot get off the ventilator, the longer their stay will be in the ICU. And in these days and time, we really want to shorten their stay because why? The longer the stay in the ICU, definitely there's going to be increased cost of care, and you're going to be burdening the healthcare system at large. When looking at our European and American counterparts, when the severely sick and ill COVID patients flood the ICU, the resources are just so strained because there's lack of manpower, there's lack of ICU capability to support our already ill patient on top of the COVID patients that come into the ICU. So these are the different factors that we have to take into consideration when we are managing and caring for these patients on mechanical ventilation. So with that in mind, I have to shift the frame to focus more about the mechanical ventilation. How do we actually manage patients on mechanical ventilation? So if you can see this screen, this is something that I am glad to say that I don't really see this often, but on the rare few occasions when I come around doing my patient assessment, if I see this is really, really my pet peeve. Nowadays, modern ventilators, you can actually configure the screen to specify what you want the screen to depict. And this is what I call the bare minimum screen. And some of our clinicians or nurses, they like to put this on, especially when it's at night. And you do not want too much light from the ventilator that can affect the quality of the sleep of the patients. Or sometimes when you have some nosy family members who are just taking pictures of the ventilators and you don't want to let them have too much information. But honestly, when I look at this screen, I find myself questioning, so what do I know about this ventilation, this patient who is on the ventilator? Honestly, nothing much. I mean, I can tell that they are on pressure control mode. I know they are still breathing because they're breathing at a rate of 22, which is above the set rate of 14, but it tells me nothing more than that, right? So you might ask, okay, so if you want more numbers, then this is the next screen. And this is actually very, very commonly seen, at least in some of the hospitals I've been into, especially in for patients who need to be isolated. So the nurses tend to put the screen big like this, showing all the variables and parameters with big font so that you can actually see the screen from outside the patient's room. Now, fair enough, I can appreciate a lot more of what's going on in this screen, because all I see is just one time section that is going on there that you cannot tell what's going on in the full breath. You can tell that there's one inspiratory phase going on, an expiratory phase, but you don't know what's happening in the next breath. This is what synchrony is all about. It is the textbook, picture perfect waveform that you show students, anyone who is learning about this, that this is what synchrony is about. Let me just orientate you to a typical ventilator screen. The topmost waveform is usually your pressure waveform, followed by the flow waveform, and lastly, the volume waveform. If you can see here, if you put a mirror, if you put a ruler here and draw an axis down, everything is in sync perfectly. When a patient could be triggering, could be time triggered, it could be patient triggered, the flow delivers and the volume, everything looks synchronized. And that is really what we hope to achieve in most of the patients. And so this is a screen that I want to ask you guys right now. Do you think that there is synchrony taking place or asynchrony? And you'll be like, what? Did I hear you correctly? Well, synchrony is when there is perfect harmony between the ventilator and the patient's interaction, right? So here, actually, I would say that it is actually both, because we are setting a set rate of 14 and the total recorded breath is 14. In a sense, I think the patient is all really knocked out and not triggering any breath. So that is actually asynchrony, because there's nothing to sync to. And all the patients are breathing is all the controlled breaths that is being delivered by the ventilator. So what about this? You can see that these days, ventilators are really smart and they are really equipped and designed to help clinicians best manage patients on mechanical ventilator. If you can look at this screen here, this is yet on another ventilator. You can see that there's different colors in the breath, and it is really colored distinctly to tell you that, hey, this breath that is in red is actually a machine triggered breath, but the next breath that is in yellow is a patient triggered breath. So the difference in colors can highlight to you that, hey, the patient is actually triggering his own breath. And in between, if he or she does not trigger, the ventilator is going to give that breath. And I will find myself asking, so is the patient fighting the ventilator? Not so much. I think that it is still in sync. I can see that there's actually about more of an effort here. You can see that there's an increase in flow, and similarly, the volume increase, because in pressure control, we are controlling the pressure while allowing the volume and the flow to fluctuate according to patient's needs. You can see here that the second breath, there's a bigger effort, and the third breath is going to be a even bigger effort than the previous one. And the volumes are really variable to how much the patient wants. So in this case, I would actually suggest that the pressure control mode is actually a little bit more comfortable for the patient who is spontaneously breathing. Now, when we look at the flip side of the coin, when you talk about pressure control, inevitably, we have to talk about volume control. Let's take a look at this. What is happening here? So remind ourselves that in volume control, we are setting a specific targeted tidal volume. And when we specify the target tidal volume, we're actually allowing the pressure and to actually fluctuate. So you can see here the flow is actually set at 50 liters a minute, inspiratory flow. So the flow is set and it is going to be fixed. The volume is set at 400 mils and it's going to be fixed as well. But guess what? The pressure is actually fluctuating because why? This patient is actually gasping for air. But because we already specified that, hey, the peak flow can only be 50 liters per minute, that's all the patient's going to get. If I were to look at this screen alone, I will think, hey, it's not so bad. Everything looks kind of in harmony except for this big dip in the inspiratory pressure. Well, it could be patient is taking a big breath. How do I actually know if patient is gasping for air? The key is the patient. We have to look at the patient. So if you take your eyes away from the ventilator and look at the patient, probably this is what you're gonna see. Diaphoretic, nasal flaring, which is a classical sign in neonatal and pediatric patients when they are severely air hunger. The first thing you'll see is nasal flaring. This is actually also can be seen in adult patients, especially when they are severely air hunger, just gasping for air. You can see them using their SCM, all their accessory muscles, and if you were to like rip their patient gown open, you can see that there's all the retractions. They are probably tachypnea. So as a clinician, if we have set the alarms, parameters and settings appropriately, it would start to alarm. But sometimes I would say that not everybody look at the alarms. So this sometimes might be missed. So if you just look at the ventilator and not the patient, we might be not getting the full picture here. And this is also the point that I want to maybe bring out the fact that people have suggested that we should be remote monitoring patients on mechanical ventilations who are in isolation. So for example, the COVID patients, they were saying, oh, we can actually like tee it such a way that the ventilator screen is outside the patient's room and we can just change the settings on the ventilator. But as a clinician, as a respiratory therapist who cares for patients on mechanical ventilator, I have to be really honest. I don't really agree with that recommendation because I want to be able to look at the patient and look at the ventilator to know what is going on. I don't think that anybody can get a full sense of what is going on with the patient by just looking at the ventilator. So if you were to remotely adjust and change the settings outside of the patient's room, because technology allows you to do so, that might not necessarily be in the best interest of the patient, right? You don't want this patient to be suffering. And the next thing you know is that when we see the patients bucking the ventilator or fighting the ventilator with the alarms going on, guess what? The next thing is that the nurse is going to page the doctor and say, hey, can we just push more sedation? We need to keep the patient calm, so that he doesn't accidentally self-extubate, which is, of course, what we do not want, especially when it is going to be an aerosol-generating procedure to re-intubate, not only just like putting everybody at risk. So we have to look at a patient to know what's going on, right? We can't just monitor from outside. And I know that some ICUs can actually do that, like just change the settings on the computer. But at the end of the day, the focus on the patient is pretty much irreplaceable, I would say. So when we look at synchrony, we really are looking at what is taking place when the patient takes a breath, draws a breath in, and the ventilator, sensing that trigger, the patient trigger for the breath, is going to deliver the tidal volume, be it pressure driven or volume driven, is going to deliver as and when the patient triggers or start the breath. Similarly, in exhalation, we can determine it by cycle time or the end of peak flow. When the flow tapers down, that's when the ventilator switches from inspiratory phase of the breath to expiratory phase. And when everything is in synchrony, we call it just harmony, perfect harmony, right? There's nothing really to sweat over it. And this is actually the opposite of synchrony. It's asynchrony. It is a total mess. So if just to recall, top line pressure, middle flow, bottom volume, you can see that there's a lot that is going on here. The waves are in a hot mess. You know, there's yellow lines that is typically the inspiratory, blue lines the expiratory for this ventilator. It is not in sync at all. The patient is fighting. If I were to give you the full screenshot, actually the full picture of the ventilator, you can probably see there's probably a lot of alarms going on. And specifically, I would like to point your attention to the fact that the peak inspiratory pressure is actually hitting 40 cm water, which is usually at the higher end of the upper limits that we are comfortable with. This patient is not a happy camper. He is not happy at all. He's coughing, he's fighting, he's taking in those big deep breaths, trying to get the air, but somehow he's not getting enough because it's limited by the volume. So he is definitely thrashing around. And when you think about dyspnea on a patient who is on mechanical ventilation, it is actually quite startling. You want to take that breath, but the ventilator, that your only source of air that you can get, is not working in harmony with you. Do you think you'll be alarmed? I would be. I don't have to be a patient to know that. I've never been intubated, but that sensation cannot be pleasant, right? And that is really what this is all about. Just the ventilator and patient is just fighting. And you can't really, when there's disharmony and asynchrony, there's no way we can deliver the tighter volume. So what happens? There's a whole lot of bad implications that happen as a result of asynchrony, which is something that is not always picked up, I must say. So we do have to define these terminologies that is used. You know, and if you have used a lot of ventilators before, you will know for a fact that different ventilators like to name their modes differently, sometimes with proprietary names. And this is, I would say, a similar theme in the respiratory care world, especially when it comes to synchrony and asynchrony and dyssynchrony, because people do not really have an established properly defined terminology. But what is accepted is at least minimally these three. When synchrony, you know, everything is occurring in and existing at the same time. There's perfect coordination between the ventilator supply as well as the patient's demand, the need for their respiratory needs. So asynchrony is when there is a lack of synchrony, you know, just simply an absence. So it could be that the patient is totally flat and not triggering anything, and it may look peaceful, because if the patient is not triggering anything, the ventilator is just going to provide the patient with whatever that is being set by the clinician. Or it could be the other end of the picture, where there is no harmony at all when patient is fighting. Now, this synchrony is actually some sort of in between, when there is some sort of synchrony, but it doesn't really match what the patient needs. So there is also some, it is called really a bad synchrony, because it is not working as it is intended to, right? So it's really all about the timing, and actually more than that. So we have to look at the anatomy of a mechanical breath here. And there, depending on at which part of the breath the patient is at, there are different things that can go wrong, right? The orange part that you can see over here is when there's a slight dip in the pressure waveform, and that's what triggers the breath. So the breath starts, and we are in our inspiratory phase. And nearing the plateau, at the end of the plateau, we are going to be cycling to our expiratory phase. A lot of times is when this triggering goes wrong, or when cycling goes wrong. Usually during the plateau is when patient is getting the breath, so everything is reasonably okay, right? So when we look at asynchrony or dyssynchrony issues, there are different things that we can take note. For the inspiratory phase, usually there can be trigger delay, there can be a flow mismatch, can be premature cycling or delayed cycling or reverse triggering. So all these are like jargons and they throw about, and this is what I found when I look for more information on asynchrony and dyssynchrony issues. And really, we'll break it down one by one later in the coming slides. During the cycling phase, we can also have double triggering or reverse triggering. Kind of looks the same, but not quite. We can have delayed cycling. We can have expiratory muscle contraction that will actually prompt us to have reverse triggering. And during the expiratory phase, it can be auto-triggering. That can be caused by some artifacts. There can be ineffective inspiratory effort, so that there's actually not no triggering. So we'll take a look deep, we'll delve deeper in them. So first of all, auto trigger. These are breaths that are generated due to artifacts or inappropriate thresholds, resulting in multiple breaths delivered that is not triggered by the patient. So if you can see here in this red box, these are cardiac oscillations that's triggering the ventilator at 24 breaths a minute, and the flow trigger is actually set at 2 liters a minute. When we notice this, because hey, you know, there's some like big swings of flow in the flow going on here, so it could possibly be triggering the breath. We actually increase the flow trigger to 8 liters a minute, and actually the flow rate gradually decrease back to the set rate of 16 breaths a minute that you can see at the diagram B. And it is interesting to note that the cardiac oscillations are actually producing a flow of up to 4 to 6 liters that's actually triggering that breath. So this is actually more commonly seen than you will realize, because some of the very thin patients with bounding chest wall, they could be triggering the ventilators unintentionally. And a best way to look at is to look at the patient and then look at the ventilator, see, is the patient taking the breath? Sometimes the patients can be totally fine and perfect with whatever set rate you give them, and they can be just breathing at the set rate, which is fine. And when you see that the patient is actually not triggering a breath, but the ventilator is giving the breath, that could be an auto trigger. Another common source of auto trigger could be the water condensate in your circuit chamber, in your ventilator circuit. So if you are using a heated passover humidifier in your ventilator circuit, the condensate can actually accumulate in the circuits and swing around, and swing and sloshes in the circuit. It can actually mimic inspiratory demand flow that could trigger the ventilator. So we do have to get rid of these artifacts or change and manipulate the ventilator settings to get rid of the auto trigger, right? Because you don't want to give patients more breath than intended to. You might be dealing with respiratory alkalosis, which is frankly not a big deal, but further downstream at the end of the spectrum, you don't want to be dealing with like hyperinflation of the lungs, which is never good. So this is the cardiac oscillations that's triggering about 4 to 6 liters, and it's more than enough to actually trigger a breath, because most of our patients on ventilator on flow trigger, we actually set it at 2 liters, usually 2 liters per minute, and this is more than enough to trigger that breath, right? So when we look at ineffective trigger, is when the patient's effort does not trigger the delivery of breath from the ventilator. It could, and it is definitely a cause of anxiety, discomfort, leading to fatigue and hyperventilation. This is definitely something that is very, very distressing to the patient. When you want to take a breath, but someone is holding it there, like almost like holding a pillow over your face to prevent you from taking that breath. This may feel like suffocating, a sense of suffocation for the patient, and it is actually more could be attributed to insensitive trigger setting or muscular weakness, but more than often not, it's actually more commonly found in patients with obstructive airways with auto-peeping. So auto-peep, when it comes to auto-peep or hyper intrinsic peep, we can use additional peep to counter the effects of auto-peeping, but we have to do so judiciously to prevent over-distension of the lungs. So the arrows here actually indicate the missed triggers. Like you can see the patient's trying to trigger a breath, but it doesn't deliver flow. So there's this repeated sensations of suffocation that is definitely going to cause anxiety to the patient. Patients who are experiencing this probably will be diaphoretic for sure. This is what it looks like in a real life ventilator. This is pressure support mode. And you can see here there's some ineffective triggers. So actually, if you look at the red arrows pointing out at the flow waveform, these are actually really, really commonly seen, but almost always ignored because they would, oh, it's just a chest wall rebound or lung recoil. But actually, you know what, that is actually an ineffective trigger. And when we see that there's actually abnormality in the flow waveform, we should actively, as clinicians, actively investigate to find out what is causing this and how we can mitigate this and troubleshoot this. When we look at double triggering, this is probably one of the most common one, is when the inspiratory effort begins after the patient trigger and is out of phase. Usually it will end up in what we call breath stacking, which is one breath on top of another. First breath that is usually patient triggered, and the other one is auto triggered or ventilator triggered. And for the double triggering that is caused by the patient, usually we can mitigate this by setting a longer inspiratory time. The other ones is not so straightforward. It is usually associated with higher than intended tidal volumes, leading to alveolar overdistension and possibly worsening lung injury. So when we look at this, right, we have to be really careful here when we look at the inspiratory time. Now, I understand that a lot of times when we teach our residents, our medical students about ventilator settings, I always find them asking me, so what is the cookie cutter default settings we should set for all patients? So the textbook will tell you for inspiratory time is anything between 0.8 seconds to 1.2 seconds. And by default, you can set it at 1 second. But the key here is that whenever you apply these initial settings, we do not just apply and walk away, right? We have to apply, look at the patient, look at the ventilator, and you know, each patient is unique and individual, as is with their pathological processes, right? You do not want to just treat them as treat them like they are all facing the same and they are using the same default settings and just walk away, because that's when a lot of times they will probably fight the ventilator because they are not getting what they want. When we look at reverse triggering, it's usually caused by diaphragmatic muscle contraction induced by passive insufflation of the lungs. So this is really the neural effort of the patient that is triggered at the end of inspiratory phase, resulting in breath stacking and a greater transpulmonary pressure. So this is actually, it may appear as if it is a double trigger, but actually it is not, right? So what you would do for reverse triggering if you have detected it is that you should probably reduce the sedation and turn down the rate, as opposed to treating double triggering as mentioned before, where we should increase the inspiratory time, right? So premature cycling is when the ventilator cycles inspiratory to expiratory without allowing the patients to fully inhale, complete the inhalation. It is considered an ineffective ventilatory effort that will result in breath stacking. So you look at this flow waveform again, and this is clearly the inspiratory flow and the expiratory phase. And when you see the expiratory phase, it should actually not go back up again. When this happens, it shows that the patient is actually trying to take a deeper breath again, but the ventilator has already cycled off to the expiratory phase. So there is clearly a mismatch here. We probably should address this by increasing lengthening the inspiratory time. Flow asynchrony is actually a big one. When this happens when the ventilator does not meet the inspiratory flow demand of the patient, and this is actually more commonly found in patients who are on volume control, when we are actually dictating how much of an inspiratory flow the patient can get. So if you look at this this diagram here at A, you can see that the flow is actually set at about 30 liters, less than about 28 liters per minute. And when the inspiratory flow, it should be a decelerating waveform and not this downside loop that is actually happening here. It shows that actually patient is trying to prolong or take a bigger breath. And what it translates across is that there is a big dip in the inspiratory pressure waveform. So when we increase the inspiratory flow settings by more than double, you can see that the pressure waveform is actually more smooth. So remember this diagram that I actually shared earlier. When you have patients on volume control who are spontaneously breathing, it is really hard to dictate how much volume they can get. I mean, we can whip out our calculators and calculate the ideal body weight and multiply by 6 to 8 mils per kg of ideal body weight to try and guess what is the best tidal volume that's most appropriate for the patient. But if your patient is spontaneously breathing with an intact respiratory drive, it is going to not sit well with him, and that is actually a big cause of all the alarms, because when we have a bigger and stronger effort, there is no corresponding change in the inspiratory flow, nor is there a change in the volume, which is what the patient actually wants, a bigger flow and a bigger volume. If you put this same patient on a pressure control, you can see that because we are controlling the pressure, we are allowing the volumes to fluctuate, and we are allowing the inspiratory flow to fluctuate. This may be more comfortable for the patients because stronger effort will actually result in a bigger volume that will meet the patient's inspiratory demand. So flow asynchrony is a very big problem in volume control, and actually this is something that is quite often ignored, I must say, because there is this fear for using pressure control modes depending on the comfort level of the clinician. So patient-ventilator interactions recognize cause of ineffective ventilation and impaired gas exchange, and it can potentially lead to lung overdistension if the settings are not set appropriately, or the ineffective triggers will lead to a wasting of your patient's effort. It may cause respiratory muscle dysfunction. More than often not, it will actually result in an increased work of breathing and patient discomfort. It is really hard to imagine putting patient on a ventilator and we are supposed to be supporting their respiratory needs, but then we are not fully addressing them and end up they have to work even harder just to get that breath, right? Why is this a problem? Studies have shown that associated asynchrony and dyssynchrony issues have been associated to morbidity and mortality, a longer duration on mechanical ventilation. And if you have to be on a mechanical ventilation for a longer period, you're going to have a prolonged ICU stay. Unfortunately, is quite common and frequently overlooked. This is not actually captured as part of a regular charting by nurses or respiratory therapists. And unfortunately, they are often treated with sedation. So when people say, oh, they are fighting ventilator, we're gonna hit them more with sedation. And sometimes, on a rare occasion, I have seen people administering paralytics to just treat the asynchrony or dyssynchrony issues. I think this is a big misstep. We should really look at what is causing that anxiety and stress for the patient, instead of just trying to block it off by using a neuromuscular blocking agent, right? Unfortunately, there's no common universal and systemic approach to address this. But what we know is this, right? Patient-ventilator interaction, it really has a lot to do with the patient's native lung functions, their ventilatory drive, their muscle function, their lung compliance and resistance, their what their illness that's causing the lung deficits, as well as the effects of the interventions that we have to help the patients. We look at the patient-ventilator interface. By it, I'm referring to either endotracheal tube or tracheostomy tube. And the big problem with tracheostomy tube is that there is actually potentially a lot of leakage that is present depending on the position of the trach. But the plus side of patients on tracheostomy tube is that they do not require nearly as much sedation. We have to look at the effects of the ventilator functions as determined by the clinician. So it really has to do with the choice of mode, right? The level of support, the amount of work that the patients is dedicated by what we set. The triggering and cycling usually is by default. But what if the default settings are not suitable for the patient? As clinicians, we have to be responsive to change and alter them. And there are so many papers published to address this, so I'm not going to go into details. But more importantly, we have to realize that the key here is to be able to detect a problem and respond appropriately. So we address this by looking at the symptoms, the physical signs of the patients. As clinicians, we have to be very sensitized to the waveforms to know what is happening. We have to be able to take 2 and 2 together and put it together to get a full picture of what is going on with the patient. We have to then look at the full picture and mitigate the issues by troubleshooting appropriately. So this will all have a very tangible effect on patient outcomes. So you may ask me, which is the mode that is most appropriate to promote patient-ventilator synchrony? It really depends on the patient, right? So for example, if I have a patient who is like totally flat and I'm putting him or her on paralysis because severe ARDS, I want to reduce oxygen demand, volume control is the best mode to go to, right? Because I can assure that this patient is going to get this minute ventilation. Whereas if I put the patient on pressure control and the patient is fully paralyzed and sedated, not so much of a good idea, right? Because the volume actually will fluctuate according to the patient's lung compliance, and downstream in the pathological processes, the compliance may change. So your ventilation may be affected. But more importantly, I would put it to you that the clinician actually plays a bigger role in this whole equation, right? Because while the clinician can actually give some pharmacological intervention, for example, bronchodilator, if patient is having bronchospasm, we can give them sedation to help calm them somewhat to achieve and promote synchrony with the ventilator. The clinician also set the parameters, the variables on the ventilator, choosing the optimal settings, the PEEP, inspiratory time, the amount of support used to drive the breath. And we can look at automation, which is a full lecture in itself. But this takes a lot away from the clinician, but I must add that the caveat is this is not suitable for all patients, and it's only really selected patients that can benefit from automative modes. So really at the bedside, the clinician is the only one who can recognize asynchrony issues by examining the patients and observing ventilator waveforms and parameters. And we have the responsibility to watch out for any async ventilator, and hopefully we can get them off the ventilator as soon as possible. So thank you for your time, and if you have any questions, I can be reached at this email.
All right, thanks, Ivan, for the very comprehensive talk on patient ventilator asynchrony, and for the reminder that in troubleshooting any forms of patient ventilator asynchrony involves looking at both the patient and the ventilator. All right. So without further ado, I would like to just move on to the last talk of this track, which will be given by Dr. Esther Tan. Unfortunately, due to time zone differences, she would not be able to join us physically, and her talk is a pre-recorded session. Feel free to just send your questions in via the Q&A tab at the bottom of the screen, and we will get back to you via the website with the questions answered. So, Dr. Esther Tan is a consultant at the Singapore General Hospital, Department of Respiratory and Critical Care Medicine. Special interest includes intensive care medicine and interventional pulmonology, specifically in pleural diseases, as well as medical education, where she is a clinical assistant professor with the Duke NUS Medical School. She was awarded the Singapore Ministry of Health Manpower Development Plan Scholarship, and she is currently on fellowship in Toronto, Canada, with the critical care program at the University Health Network and Sinai Health System. So without further ado, we would go ahead with her pre-recorded talk.
I would like to thank the organizers of APICS 2020 for the invitation to speak today. My topic is on NIV and high flow oxygen therapy for respiratory failure, the use pre and during COVID. I have no disclosures. So the outline of today's talk would be on NIV and high flow in acute respiratory failure. I'll review the evidence and the guidelines, as well as to compare both modalities of non-invasive oxygen strategies. I will also then speak about their use during this pandemic. So non-invasive mechanical ventilation has its history and origins in the iron lung, invented in the 1920s, which played a crucial role during the polio pandemic in the 1940s and 50s with the application of negative pressure to the airways. Subsequently, with successful vaccination programs and the eradication of polio, along with the increase in positive pressure invasive mechanical ventilation, use of NIV declined. NIV then experienced a renaissance with the invention of non-invasive intermittent positive pressure ventilation and continuous positive airway pressure, CPAP, via a non-invasive interface, and nowadays is a medical intervention used in daily practice worldwide in many clinical settings, both in acute critical care and also in the ward or home. So this is a summary table of recommendations from the ERS ATS guidelines from 2017 for adult NIV use. NIV use is recommended for hypercapnic COPD exacerbation and cardiogenic pulmonary edema with moderate to high certainty of evidence, whereas for de novo respiratory failure, defined as acute hypoxemic respiratory failure in absence of underlying chronic lung disease or cardiac failure, as well as in pandemic viral illnesses, no recommendations were made, and I will elaborate more on these in later slides. In general, gas can be delivered to the airway via a mask or interface compared to an invasive conduit for invasive mechanical ventilation. The open breathing circuit permits air leaks around the mask or through the mouth. So different interfaces are as shown here. from nasal masks, usually used for chronic applications, to nasal pillows with a chin strap, which will be more comfortable. The oral nasal mask with a head strap covers both the nose and the mouth and is usually used in acute settings, mainly in trials evaluating NIV in acute respiratory failure. This is a mouthpiece with a lip seal and a full face mask. The helmet, as seen here, is a transparent hood that covers the entire head. It also has a collar neck seal. So based on guidelines, use of bi-level NIV is strongly recommended to prevent intubation in acute or acute on chronic respiratory acidosis secondary to COPD exacerbations. The evidence is strongest, especially in patients with a pH of 7.25 to 7.35 in the absence of metabolic acidosis. And the trial of bi-level NIV should be considered unless the patient is immediately deteriorating. Improvements in observed physiological measurements such as pH or respiratory rate is a good predictor of successful outcomes, and response is usually seen in the responders within the first 1 to 4 hours of initiation of NIV. Use of bi-level NIV has also demonstrated to reduce mortality compared to standard care. Another indication for NIV is that of cardiogenic pulmonary edema by reduction in preload as well as left ventricle afterload. NIV is associated with a reduction in hospital mortality with similar effects of CPAP and BiPAP. It also reduces intubation rates, and of note, most studies exclude patients with acute coronary syndrome or cardiogenic shock. With regards to de novo respiratory failure, the first RCT by Antonelli and colleagues to suggest a possible role for NIV in patients with hypoxemic respiratory failure was carried out in 1998. Comparing face mask NIV versus invasive mechanical ventilation, they showed that with NIV, there were similar improvements in PF ratios within the first hour, and more patients in the IMV group had increased complications like pneumonia and sinusitis related to endotracheal intubation. They also had a longer duration of ventilation and ICU length of stay. However, since then, there's been an uncertainty of evidence, and the ATS-ERS guidelines do not offer a recommendation of NIV in de novo acute respiratory failure. The findings from the lung SAFE study was also helpful in describing NIV use in ARDS. This prospective observational international multi-center cohort study of 459 ICUs is one of the largest prospective data sets of patients with well-defined ARDS treated with NIV. They looked at 2,813 patients diagnosed with ARDS criteria within 2 days of developing acute hypoxemic respiratory failure. 18% were managed on NIV on day 1, and 15.5% were managed with NIV on day 1 and day 2 of ARDS. One of the main findings was that there was no major difference in the rate of NIV use across severity of ARDS. In the mild, 14%, moderate 17%, and severe 13%. And mortality rates differed amongst the groups, with higher failure rates of NIV in severe ARDS, where NIV failure was associated with increased risk of death at 45%, which was higher than that for severe ARDS patients managed on invasive mechanical ventilation. Also, in a propensity-matched cohort, ICU mortality was significantly higher for NIV than invasive mechanical ventilation in patients with a PF ratio of less than 150. Hence, it raises the question if NIV should be used at all in sicker patients with ARDS. The number of immunocompromised patients have also increased over the years with advances in solid organ and stem cell transplant, cancer screening, detection and management, as well as immunosuppressive therapy. One of the main reasons for ICU admission in these patient populations is acute hypoxemic respiratory failure, which is associated with a high mortality rate, particularly when invasive mechanical ventilation is required as endotracheal intubation, which predisposes to nosocomial bacterial pneumonia. Hence, the interest in NIV techniques to provide ventilator assistance. So these two are landmark RCTs that were carried out by Antonelli and colleagues in 2000 and Hillcrest and colleagues in 2001. The immunocompromised populations were that of the solid organ transplant population in the Antonelli study, while the study by Hillcrest looked at patients with hematological malignancies, neutropenia, chemotherapy, and AIDS. Both studies did show potential benefits for NIV in immunocompromised patients with hypoxemic acute respiratory failure to avoid the potential complications of endotracheal intubation. Gas exchange improvements were both rapid as well as sustained, and NIV was noted to be well tolerated. They also demonstrated lower endotracheal intubation rates, lower rates of complications like sepsis, as well as ICU and hospital mortality. All patients with ventilator-associated pneumonia died in both studies, and hence the practice of avoiding intubation seems to remain a goal in the management of immunocompromised patients, independently for NIV use, mainly to avoid nosocomial infections. A post-hoc analysis on this cohort of immunocompromised patients in the LungSafe study was performed by Cortigiani and colleagues, and they found in this cohort there were 20.8% of patients who were immunocompromised. The main reasons for immunosuppression were that of neoplastic disease, immunosuppressive drugs, or viral immunosuppression, as well as patients with active hematological malignancy or neoplasm. So they described the use of NIV as the first-line treatment being higher in the immunocompromised patients at 20.9%, with immunodeficiency remaining independently associated with use of NIV even after adjustment for confounders. There was also a higher incidence of NIV failure in the immunocompromised group, with significantly higher hospital and ICU mortality, despite similar ARDS severity and non-pulmonary SOFA scores. With this, they noted more frequent decisions to withhold or withdraw life-sustaining measures in the immunocompromised patients. So perhaps the harm associated with NIV should be talked about. We do know in spontaneously breathing patients with either acute respiratory failure or ARDS, there's an increase in respiratory drive and inspiratory effort while on NIV. So these patients may then generate large tidal volumes that are above those considered lung protective. And these large tidal volumes in the baby lung would then increase lung stress. So this diagram here shows advanced respiratory monitoring with esophageal pressures during spontaneous breathing. And as you can see, there is huge inter-individual variability of inspiratory effort. Also, in the injured lung, as the diaphragm contracts, there is a heterogeneity of local transpulmonary pressures, where local negative pleural pressures are concentrated in the dependent lung. There is then a shift of air from non-dependent to the dependent lung regions without a change in tidal volume, i.e. a pendular phenomenon, which then leads to a hidden local overstretch of the dependent lung regions itself. This also leads to an abnormal increase in vascular transmural pressure with an increased vascular permeability and negative pressure pulmonary edema. The diaphragm itself, due to high mechanical forces within the muscle, can also be injured. Prolonged NIV without evidence of respiratory improvement may also lead to a delay in intubation, which perhaps then leads to a greater mortality than those who were intubated earlier, mainly because of a lower respiratory reserve in patients who were delayed, the increased risk of aspiration pneumonitis, as well as potential greater instability during induction of intubation. Also, a delay in ICU evidence-based care and investigations may occur, such as NIV may prevent mobilization or enteral nutrition for the patients, and also there is a higher risk of invasive diagnostic tests such as bronchoalveolar lavage. There can also be patient discomfort from face mask interfaces when the use of high levels of positive and expiratory support and pressure support occurs. While trying to avoid air leaks around the mask, there is a need to use greater strap tension, and with this, it intensifies mask discomfort, intolerance, and patient-ventilator asynchrony. It is then not surprising that NIV failure is associated with higher in-hospital and ICU mortality than patients who have NIV success or patients who were put on invasive mechanical ventilation as first-line therapy. So this is a list of risk factors for failure of non-invasive oxygen therapy, which mainly include patient factors like underlying malignancy, pulmonary infection, and a prolonged duration of hospitalization prior to ICU admission. At the same time, greater severity of illness and ARDS, as well as a lack of physiological response when put on NIV. And of course, patients who were having a higher tidal volume response when on NIV. Other predictors of NIV failure are as listed. It's quite similar to the ones from the slides previously. And of note, I'd like to emphasize the Acp Score here, which has 5 different points of heart rate, acidosis, patient's conscious levels, oxygenation in terms of PF ratio, and frequency of respiratory rate. The highest score is that of 25, with a cutoff of more than 5 at 1 hour, predicting failure with a diagnostic accuracy of 81.8% in the testing cohort and 86% in the validation cohort. Further trials have also evaluated these predictors of NIV failure, such as this pilot study by Tonelli and colleagues, who enrolled 30 patients with acute hypoxic de novo respiratory failure for a 24-hour NIV trial with measurements of esophageal pressure while on NIV. So they describe patients who successfully completed the NIV trial as those having lower changes in esophageal pressure and the ratio of tidal change in esophageal pressure to transpulmonary pressure. The magnitude of inspiratory relief was strongly associated with avoiding represented the most accurate predictor of treatment success. And compared to other predictors, such as in this table here, change in esophageal pressure of less than 10 cm of water within the first 2 hours after NIV initiation was an early and accurate predictor of NIV failure at 24 hours. The use of different non-invasive interfaces has also been studied, such as this RCT by Patel and colleagues that evaluated NIV via helmet versus face mask interface. So often higher levels of PEEP will lead to air leak and intolerance of the face mask with reduced efficacy, and an alternative then is to deliver NIV via a helmet interface. So the helmet interface itself comes with a transparent hood that covers the entire head of the patient with a soft collar neck seal, and it's secured by padded armpit braces attached to 2 hooks on the front and the back of the plastic ring, connecting the helmet to the neck seal. The helmet is then connected to the ventilator with both an inspiratory and expiratory limb and flow. So this trial was stopped early for efficacy, and it showed reduced intubation rate, improved ventilator-free days, and reduced hospital and 90-day mortality in patients who were on helmet NIV. Advantages of this potentially were that the higher PEEP levels could be delivered with less air leak. There was then improved patient tolerability and seal integrity at the neck. I'd like to move on now to high-flow oxygen therapy. And as we do know, high-flow oxygen therapy comprises mainly of a nasal cannula with a head strap, a humidifier, an oxygen flow meter, and depending on the system, such as in this MR850 system, you can go up to 60 liters per minute. The temperature can also be adjusted according to patients' comfort levels. And these are the indications and clinical uses of high flow that are quite known. And today we will focus more on the use in acute hypoxemic respiratory failure. The benefits of high flow oxygen therapy namely include the provision of heated and humidified gas, which improves mucociliary clearance and reduces airway inflammation. It also reduces the metabolic cost for gas conditioning. With the provision of high flow, it can help to match the patient's inspiratory demands to minimize oxygen dilution due to air entrainment. The increased expiratory resistance also provides a PEEP-like effect. with emphasis on flow and prevents alveolar closure with an increase in end expiratory lung volume. The insufflation of fresh gas also helps with nasopharyngeal dead space washout and a decrease in anatomical dead space with improvement in alveolar ventilation. Patients are also better able to communicate and even feed orally, leading to improved compliance, and the device allows for separate titration of oxygen and flow and is easy to implement. So this is a schematic representation of the physiological effects of nasal high flow and the possible impact of flow with an increase in airway pressure, FiO2, and dead space washout, which leads to a decrease in respiratory drive, respiratory rate, work of breathing, and respiratory effort. And together with the provision of humidity, this will overall improve patient comfort and possibly outcomes. Failure of high flow can be seen by progressive respiratory failure, hemodynamic instability with need for increased ventilatory support. And delay in intubation has been described to be associated with worse outcomes, such as in the study by Kang and colleagues. And hence, it leads us to the importance of early and accurate predictors of high flow failure. The ROX index is one such score which combines in a single value the best descriptors of patients' respiratory status, and it's easily as well as repeatedly measurable at the bedside. It was first described by Roca and colleagues as part of a prospective observational cohort study with 157 ICU patients with pneumonia, and it showed that the ROX index of greater than or equals to 4.88 was less likely to need mechanical ventilation. And this is even after adjusting for potential confounders like chronic respiratory disease. The ROX index was then further validated in a prospective observational cohort study with a second external validation in the Florelli cohort. And they similarly showed that the ROX index of greater than or equals to 4.88 measured at 2, 6, and 12 hours after initiation of high flow was consistently associated with a lower risk of intubation. This is a suggested algorithm using the ROX index to aid in decision for intubation. And for each time point, there are 3 possibilities. So if the ROX is below 2.85 as a cutoff value, the physician is suggested to consider endotracheal intubation. If the ROX index is between the lower and the higher cutoff values, the suggestion would be then to increase the level of nasal high flow support and to reevaluate again after 30 minutes. And if the ROX itself index was above the higher cutoff, high flow can definitely be continued, but monitoring is important. Studies have also shown that most intubations tend to occur between 12th and the 24th hour. Therefore, monitoring with the ROX index is suggested with a special focus from the 12th hour onwards. Modifications to the ROX index have also been studied, such as this one here with the incorporation of heart rate. So this is a prospective observational cohort study by Go and colleagues in 145 patients, whereby the ROX index was modified with incorporation of heart rate, which was found to add value to prediction of accuracy, and it also allows for early identification of treatment failure. As seen here, a ROX heart rate index of greater than 6.8 was significantly associated with a lower risk of high flow failure at 2, 6, and 10 hours. The association was also further observed at 18 and 24 hours, even with correction for potential confounding factors. Moving on then next to comparing nasal high flow with NIV. I'd like to highlight a few landmark trials, beginning first with the trials by Lemille and colleagues. So this is a comparison of early NIV versus oxygen therapy in 374 critically ill immunocompromised patients. And what they found was there was no significant difference in survival at day 28, as well as in intubation and ICU length of stay. Of note, there was a confounder of high flow oxygen therapy use in both groups. This was followed then by a prospective multi-centered RCT by Fred and colleagues in 310 patients, whereby they compared high flow oxygen therapy with NIV and conventional oxygen therapy to see if there was any potential reduction in endotracheal intubation rates or improvements in outcomes such as mortality. What they found was there was no significant difference in intubation rates, although the number of ventilator-free days at day 28 was significantly higher in the high-flow oxygen therapy group. And similarly, in the post-hoc analysis, there was significantly less intubations in the high-flow oxygen therapy group in those with a PF ratio of less than 200. There was also a significant reduction in day 90 mortality and lower dyspnea scores in the high-flow group, and a subsequent post-hoc analysis of the immunocompromised patients, of which there was 26% in the entire cohort. They found that NIV was associated with increased intubation and a higher ICU and day 90 mortality. The high RCT is the largest trial to date of 776 patients enrolling immunocompromised patients with acute respiratory failure. They did not find any significant difference in day 28 mortality, intubation, and IMV, as well as comfort or dyspnea scores, although the high flow patients showed a reduction in respiratory rate and improvements in PF ratios. So the trials are all nicely analyzed in this network meta-analysis by Ferrero and colleagues, who compared the association of non-invasive oxygen strategies with mortality and endotracheal intubation in adults with acute hypoxemic respiratory failure. So although there were no studies that were comparing directly high flow with helmet NIV, the use of a network approach leverages direct evidence from published clinical trials that share common comparators to then generate indirect evidence in order to rank them. So separate clinical trials that directly compared helmet NIV and high flow with a common comparator such as face mask NIV can then be used to generate indirect evidence for the relative benefit associated with helmet NIV versus high flow. So in total, they looked at 25 RCTs, 3,804 patients, comparing high-flow nasal oxygen, face mask NIV, helmet NIV, and standard oxygen therapy for both all-cause mortality at 90 days as well as intubation. Of note, more than 50% of the trials included immunocompromised patients. So there were in total 21 trials that were included in the mortality analysis, and using standard oxygen therapy as comparison, as reference, helmet NIV and face mask NIV were significantly associated with lower risk of mortality, although there was lower mortality risk in high flow. This was not statistically significant. There were 25 trials that were included in the analysis of endotracheal intubation and compared to standard oxygen therapy. Helmet NIV, face mask NIV, and high flow were all associated with a lower risk of endotracheal intubation. Of all the possible interventions, helmet NIV had the best probability of reducing all-cause mortality and endotracheal intubation. And perhaps helmet NIV and face mask NIV should then be considered as distinct therapeutic interventions. Also of note, there was no significant difference in association with mortality and intubation when comparing face mask NIV with high flow. Although this is a busy slide, I think it's a good summary. It's the algorithm proposed by Sklar and colleagues for the consideration of non-invasive oxygen therapies in acute respiratory failure in onco patients, although perhaps it can be extrapolated for the non-immunosuppressed patients too. So important factors to consider really would then be the etiology and severity of illness, as well as the severity of acute respiratory failure or ARDS. The importance as well of the review of potential risk factors associated with failure, and the importance for close monitoring for response of either physiological variables or the tidal volumes to the modality chosen, with the main aim to avoid delays in invasive mechanical ventilation. I'll now like to move on to what can be used during the whole COVID period. So drawing evidence and experience from previous outbreaks, such as the 2003 SARS pandemic, it was found that 21% of patients affected were actually healthcare workers. You and colleagues also performed an analysis of risk factors for nosocomial outbreaks of SARS among hospitals in Guangzhou and Hong Kong. And they found that factors responsible for hospital spreading of SARS included a minimal distance between beds of less than 1 meter, availability of washing or changing facilities for staff or staff that came to work while experiencing symptoms, as well as resuscitations that were performed in the ward, and whether or not the host patients required oxygen therapy or BiPAP. And this perhaps led to concerns of potential super spreader events with the use of oxygen therapy and NIV during pandemics. The 2017 ERS and ATS guidelines also were unable to offer a recommendation given the uncertainty of evidence, which were mainly observational studies on H1N1 infection and other coronaviruses, also showed a high failure rates while on NIV. Hence, they suggested for cautious NIV trials in carefully selected patients at experienced centers in a protected environment. So the development of hypoxic respiratory failure in COVID-19 infected patients initially resulted in a very fast track to proceed from low flow oxygen supplementation via nasocannula to a non-rebreather face mask, and then directly to intubation and mechanical ventilation. And reasons for this include the concerns for rapid decline in respiratory status, and also the aim to mitigate viral spread and transmission to healthcare workers, such as with limitation of entry after intubation to the infected patient's room, and avoiding potential aerosol generating procedures. However, there were also concerns with regards to invasive mechanical ventilation, and studies have shown that the predominant aerosol generating procedure of concern is that of tracheal intubation, tracheostomy, and manual ventilation before intubation itself. IMV also comes with other risks, such as ventilator-induced lung injury and healthcare-acquired pneumonia. There were also concerns with regards to limitations to equipment and resources during this pandemic. Since then, there are varying recommendations on non-invasive therapies for COVID-19 from the different scientific societies. And this may be a result of different environmental factors such as facilities, ICU bed availability, experienced personnel, equipment. And for example here, the Italian Society strongly recommend the use of helmet NIV, for which they have a lot of experience. And most recommendations of note are based on expert suggestions, and the level of evidence thus far has been weak. From published observational series in major journals, the trends of NIV and high flow usage have been reported. So as shown here are some values of both the mean NIV as well as high flow usage. And what has been observed is that this varies amongst the different countries, and high flow failure was associated with a lower PF ratio. There's also been an abundance of medical literature on COVID-19, including studies on potential aerosolization while using the different oxygen modalities, such as this one here, which looked at the exhaled air dispersion distance with high fidelity patient simulators, and it shows differences in dispersion distance between the different oxygen modalities, such as high flow, whether or not the nasal cannulas are put on tightly, NIV via a full face mask with a single limb circuit, and helmet NIV with a tight air cushion with a double limb circuit. They also found that use of surgical face mask over the high flow nasal cannula has been found to capture 83.2% of particles, but comes at a risk of reduced CO2 clearance. Regardless, there remains an evidence gap between the demonstration of aerosolization and its impact upon infection risk to the healthcare worker, especially when wearing adequate PPE. So recommendations on PPE include those on respiratory, eye, body, and hand protection. As seen here, the FFP2 respirator, the American System Classification of the N95 is equivalent to it. And regardless of society or guidelines, the consensus remains that it's essential to protect the teams of healthcare professionals managing suspected or COVID cases, suspected or confirmed cases of COVID-19. It's also important for strict adherence to infection control guidelines and hand hygiene both before and after patient care, the availability of protective equipment, as well as competency in both donning and doffing of PPE is essential. I'd like to end with this paper by Rolf and colleagues who suggested an algorithm and approach to management of COVID-19 patients with acute respiratory failure. They first stratified the patients according to the severity of respiratory failure, patients that are not in respiratory distress, those that are in mild to moderate, as well as severe respiratory distress. They did consider both modalities, high flow as well as NIV, and they looked specifically as well into awake proning, as it may result in better physiological effects on VQ mismatch, better drainage of purulent lung secretions, and a greater homogeneity in lung mechanics while receiving pressure support. Regardless of the techniques used, of which they describe in detail, the importance really is of aerosol mitigating interventions such as negative pressure rooms, HEPA filter use, and PPE for healthcare workers. And importantly as well would be monitoring with early intervention if the patient is not doing well. In summary, NIV in acute respiratory failure is strongly recommended for COPD exacerbation and acute cardiogenic pulmonary edema. There remains favorable evidence, however, for use in de novo respiratory failure, including the immunocompromised population, especially with concerns of harm from patient self-inflicted lung injury. There's also a growing interest in NIV use with different interphases, and perhaps the face mask and helmet NIV should be considered distinct therapeutic interventions with potentially different physiological and clinical effects. As for the use of high-flow oxygen therapy in acute respiratory failure, studies focus predominantly in the immunocompromised population, and evidence still remains variable. Regardless, considerations for any modality use include the etiology and severity of acute respiratory failure, its reversibility, the impact on tidal volume, and the monitoring of response to respiratory physiology variables and tidal volume. In this COVID-19 acute respiratory failure era, there's also a role for both NIV and high flow in the less severe population. And although there are concerns regarding aerosolization and super spreader events, there is an evidence gap between aerosolization and infection risk. Hence the importance and emphasis on aerosol mitigating interventions and PPE. Finally, what is evident is that one size does not fit all in this heterogeneous population of patients with acute respiratory failure. And choosing the right non-invasive oxygen support likely requires a precision-based approach to match a given strategy to the observed phenotype of acute hypoxemic respiratory failure, and together with clinician experience and comfort with each modality. Okay, and with that, I've come to the end of my presentation. Thank you for your attention.
All right, thanks Esther for the very detailed talk on high flow nasal cannula and NIV. So with that, we have come to the end of track 10, where we covered various aspects of ventilator management of respiratory failure in ARDS, whether in COVID or non-COVID states, management of patient ventilator asynchrony, and finally an analysis and breakdown of evidence behind the use of high flow nasal cannula and non-invasive ventilation in pre-COVID and COVID times. I understand there are some questions in the Q&A panel, but because we have two speakers who are not here physically, we would forward the questions to the respective speakers, and do check back 2 weeks later on the APICS website for answers. So with that, I would like to end off track 10, and once again, I thank you all for your ongoing support for APICS 2020, and I wish you a good evening. Stay safe, take care, and goodbye.